Welcome back to Hot Air, Cool People with Dr. Gunz. This is part 2 of our 3-part series with Dr. Ingrid Waldron. In this episode, we dive into the policies and lived realities at the heart of environmental racism, including Bill C-226, Canada's first environmental justice law, which Dr. Waldron co-developed.
Again, I can think of about 4 questions out of what you've just said. I think the first one is just a reflection when you're talking about community-based research. In a way, it's really like connecting and you're a resource. So there's this very reciprocal piece and enabling. And I think that's one interest, just to even go to Bill C-226. How can communities, so now that it has passed, which is phenomenal, how can communities use that bill to support the work that they need to do from an environmental justice perspective?
Yeah, so the Bill C-226, which was a private member's bill, which is now law. So we have our first environmental justice law in Canada, was co-developed, as I said earlier, with me and Lenore Zan, and then it was sponsored later by Elizabeth May because Lenore Zan lost her seat when we had the snap election in 2021. She lost her seat to a conservative in Nova Scotia. So the bill was then sponsored by Elizabeth May, and then on June 20th of 2024, this year, it received royal assent, becoming the first environmental justice law in Canada. And people often ask me, what can that bill do? What can that law do for communities? And I think, well, first of all, I'm not spearheading the national environmental justice strategy that accompanies the bill, that's mentioned in the bill. The Department of Environment and Climate Change is leading the national environmental justice strategy that's mentioned in the bill. And that is going to involve consultations with impacted communities impacted by environmental racism across the country. So they're leading it. But I think how it helps communities is, this is the first time ever that the department has ever done this type of work, has ever done consultations across Canada with impacted communities. So that's the first. And when we think of the definitions, the 5 principles of environmental racism, one of them is that the communities are never heard. The communities that are impacted are never heard. This is now an opportunity for the first time for the government to hear the concerns of community members. So that's important. The second reason that the bill is important and could be helpful to communities is because it addresses another aspect of the definition of environmental racism, is that the communities that are most impacted never have a seat at the table. They're never involved in decision-making and policy-making. That is one of the tenets of environmental racism. The national strategy, whereby the government will consult with communities, in addition to having their voices heard, community members will have an opportunity, I would say, to build that national strategy. And that national strategy is a policy. So they will be reaching out to communities to hear their concerns, but we've all heard their concerns. What we want is action. And I believe that some of the questions that they plan to pose to community members are, what are your suggestions for building this national environmental justice strategy? Those suggestions, to me, allow community members to be co-developers in this national environmental justice strategy, an opportunity that they've never had. So I think for those reasons, I see this being very helpful for community. I mean, there's another aspect of the bill, which is about financial compensation. I won't use the word reparations. I know people don't like that term, but basically, it's to provide financial compensation to communities that have lost out in some way. So I think the bill looks back, and the bill looks forward. There's an intention to intervene on current cases of environmental racism and also prevention, to prevent future cases, because they're learning from community members about what has happened and perhaps what should not have happened. And I'm hoping that they will learn from those experiences to put in place approaches that will prevent future cases of environmental racism. For all of those reasons, I think the bill will be helpful for communities.
Yeah, so communities can make the bill work for them as well. Um, I I think the other thing that struck me when you were, well, I think the other thing that struck me when you were speaking about environmental racism is, when you have, because you said that you felt that there was a lot of resistance and doubt and probably undermining some of this initially, and it occurs to me there's two things that you're talking about that are very hard to speak about for people to acknowledge based on bias or education, other things. And one of them was racism. And the other thing is the environment. And I think this is something that, in our work and trying to sort of move forward, what I've realized is more and more is there's this missing in Western perspectives. The environment is just not part of health. And in the medical system, which is why I love seeing patients in our clinic, people who have concerns or are wondering. So in the medical system there is, but also in communities, and especially when you see the word climate change, there's this dichotomy with people who are getting really afraid of their water or their air, but deny this existence of climate change. And then there's the politicizing of these other pieces, and people are getting pulled to actual misinformation around water and air. And I even think about I've never lived anywhere where I thought, and I wasn't born in this country. So even moving from where I was to here, I've never lived anywhere where I thought the water was just safe for me to walk in, even, not even, let alone drink it. Right. And it only occurred to me a few years ago how twisted that is, that we would even think that it would be normal for us to think it's dangerous, that the air is usually polluted. So, that you have to really go elsewhere if you're lucky enough to get clean air. And then even then, it's probably not going to be clean. That was just the way it was. And I think now, having the privilege of having a vehicle that is electric versus one. And now if I'm near one that has, combustion engine, I'm like, whoa, I smell it. One of my areas of medicine is transport medicine. So, walking into these bases, where, our, the medics I work with are, and the air, or even on an airplane, the air that you breathe, I notice it now because it's not part of my everyday. I don't smell gasoline all the time. So I don't expect it. And therefore, I know it. I think the other piece is that, as I learned about the health effects, even as a physician, of the wide disseminated health effects that we have from heat and air pollution, affecting mental health, with air quality, we've had, decades of data, and it's, associated with early onset schizophrenia in youth, in multiple cohorts, early onset schizophrenia, question of autism and depression and possibly ADHD, maybe not, and anxiety. There's less of a signal, but there's constantly data, cerebral palsy,
Yes.
as well as all of these other health outcomes, stroke, heart attacks, etc. And you can take that, the epidemiology, and you can add that environmental racism piece. But I think, when people are learning this, even when I learned this, I was like, wow. It really is. We can't see it, and it's a bit intangible because it's at the population level, or even the other way. How important, how enriched we are when we are connected with nature in some way. Our mental health, our physical health, our blood pressure, our glycemic control, our sugar control, if we have diabetes. And I remember looking into this literature and being like, wow. And there's this intangible piece. So with environmental racism, it's this multi-layered education. And, with that all said, I wonder about how, some of the work I feel in climate change and health, I've done a lot of work and asking people and really wondering what their priorities are and what they're worried about with their health. And one of the places, and we really want to do a lot of work around adaptation, empowering people with their health, and figuring out how, there's medications that needs to be changed. How do we link with community groups and community organizations so that we can, protect our communal health and lean in when we're having heat waves or, air quality waves, and people who have complex health conditions. racialized communities, indigenous communities. But, in my purview with children everywhere across all of these identities are not really being brought to the table. They're in these institutions that they don't have control about going to, like schools and, maybe job and summer jobs and summer camp. And we're not having conversations about how to protect that health, which I realize I don't want to get on a bit of a tangent, but I think where I'm coming to is how do we balance listening to community, but also bringing in education so they can use that. That actually, when we're talking about heat, it's not just being hot and having heat stroke. More kids go to the emergency room, more seniors go to the emergency, more people get admitted to hospital, more people have pneumonia. And so this is why it's really important that we lean in and tackle this issue. How do you balance listening and also supporting with education so that these decisions and these actions can be, even more enriched in communities that might not have that knowledge? And there are very educated communities. And I think more Western, communities where that knowledge doesn't exist, or that relationship with environment and health, which is, like as in non-Indigenous communities, where that relationship has been severed more.
Yes. I mean,
Yeah.
interestingly enough, the health effects of environmental racism were dismissed by the folks that I met with at Nova Scotia Department of Environment when I said I met with them a few times at the end of 2014, beginning at the end of 2014. There was a dismissiveness. And at that time, I had yet to write my book and I had yet to really publish it. I was new to it all. And they wanted evidence, that there were health effects. And I didn't have that evidence. Well, there's evidence in Canada over the past 20 years that indicate that, because we have environmental researchers and environmental sociology, environmental science who talked about the health effects in Canada. But they were very dismissive. Also, I want to point out that what you're talking about also speaks to the holistic understandings that Indigenous people have around well-being. When we talk about Indigenous epistemology, Indigenous ways of knowing, that's precisely it, that they have a much more holistic understanding the connections between the environment, between plants, animals, health. When they say you desecrate my land, you desecrate us as people, because it's part of who we are. We don't make those separations. In Western society, we separate the body from the mind. And now, in Western society, mindfulness healing and meditation and yoga are popular, but they're not Western modalities. So we have a lot to learn from both, I would say, Indigenous ways of knowing, but also African ways of knowing, which people don't often talk about. In terms of African epistemology, it's very similar to Indigenous epistemology. It's that holistic understanding of the world. So that's what's missing. And that's what I would say is missing in environmental assessments, which is that process that's used to decide where a hazardous project goes in communities. They're not thinking about the social determinants of health or the structural determinants of health or the impact on health in Indigenous communities if you put a pipeline there. Because in your Western ideology, those things are separate. There's no understanding that environmental issues, environmental degradation is going to impact on anybody's health. And that's certainly, that comes with teaching. And, I certainly teach my students about that. And I think in medical schools, in terms of training, in terms of the health professions, all of that needs to be taught. I taught for a bit in nursing when I was at Dalhousie. I'm not a nurse by any means, but, they wanted a sociologist. So here I am. And I spent a lot of time trying to impress upon nursing students the importance of thinking about environmental issues. And I got some pushback because my nursing students didn't understand what this had to do with nursing. I was teaching them the structural determinants of health, the environmental determinants of health, environmental racism. And they didn't understand why Ingrid Waldron was hired. Got a lot of pushback. It got easier later on. But I can understand why it seemed to come out of the blue for them. They wanted to know about the technical skills that a nurse had. And that's the most important. I'm not going to deny that. But I also think nurses and health professionals need to understand environmental issues, because more and more we're realizing through research that environmental determinants have increasingly the most bearing on our health and well-being and what we eat, what we're putting into our mouths. We're seeing that every day now. In terms of how I educate communities around the health effects, I have an example right now that's starting to happen that I'm very excited about. So I mentioned earlier, I'm doing a climate change project in Black communities in Nova Scotia. I've been communicating with Nova Scotia Health, maybe for the past month, about having them doing a series of online presentations to the African Nova Scotian folks um, who participated in workshops that I held in the summer of this year, in June and August. I completed 13 workshops in different African Nova Scotian communities. And last year, I held 12 workshops in African Nova Scotian communities for a total of 25 African Nova Scotian communities, for a total of over 200 participants. So I was speaking with Nova Scotia Health about doing a presentation in February that looks at the health impacts of climate change. I'm also going to reach out to someone at Nova Scotia Health to talk about Lyme disease, because that was an issue that was much discussed during the workshops on climate change with African Nova Scotians this year and last year. Lyme disease was a big issue. So I'm also going to have someone talk about the connections between climate change and Lyme disease, and also how to address it. And then I'm also planning to connect with some other folks at Nova Scotia Health about climate anxiety, the mental health impacts of climate change and climate anxiety. So I'm very excited about this connection. I had connections with Nova Scotia Health around environmental racism when I lived in Nova Scotia. So I already had that connection. But I'm happy that they now seem to have an initiative, which I don't think was there when I was living there, that didn't exist, an initiative on climate change and health. So I'm certainly planning to kind of nurture that relationship with Nova Scotia Health and the partnerships, so that they can bring the health issues into light, I think, more. And certainly the workshop participants highlighted the health issues. So I just wish that more scholars can do that. I think with environmental racism and climate change, once again, I think people are in their silos. And climate, environment, and health are often taught by professors independently, in independent ways, once again, sticking within their silos. And that government departments also don't bring those two issues together, health and environmental health and climate change. So I'm really excited about the fact that Nova Scotia Health is doing that work.
Yeah. And I think the other piece is that now communities and public, like they're starting to bring in, there's these interdisciplinary groups around some sort of issue, whether it's food or housing in a community around climate change, and they're bringing in health, but at the level of public health.
Yes.
And I still think that there's healthcare providers and people who are working at the individual level. And there's a lot of knowledge that needs to be, spread to capacity. But what I try to do more is try and link in to these where you're talking about public health, because public health is responsible for health messaging. And then beyond that, it's, the actual individuals and communities. And so I feel like this public health gets brought in now, which is phenomenal, but we're not bringing in, the individualized health that then actually needs to link in with these community organizations to help, promote health. If I have a very vulnerable, like a person who's very high risk in heat, or a senior who, what community organization can check on them and support them.
Yeah.
So,
and many of the communities shared with us that they don't even have health clinics.
Yeah.
They either don't have health clinics, or the health clinics are not open all day. Right. Accessing physicians, accessing clinics are very difficult for them. And they talked about the elderly having unique and specific problems. So you're right about that. In African Nova Scotian communities that are 99% rural, their communities, they're in rural, isolated communities. Access to physicians, access to medical care is a challenge. So you're right. The extent to which Nova Scotia Health can address that, those on the ground issues, we'll see. But you're right in pointing out that there is the public health aspect, but we need individuals to address individual experiences with health. That can be a challenge.
And as healthcare providers, this is where we need to respond
Yes.
and be creative and different.
Yes.
This isn't working. And so how can we do this differently?
But would you say the reason why it's not working goes back to what I said earlier, the training. The
Yeah, I think
training.
some of it, I think some of it's the training. I think some of it's demand. And also, healthcare providers aren't well. And I have a good friend who does a lot of work in actual on the continent of Africa, in multiple countries, looking at healthcare providers, frontline healthcare providers. And these are so is Leslie Gittings, and she does and so she's done this project, and I think now they've done the second phase where they're working with frontline HIV providers of children and youth, and how do they support their health and mental health, and 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 it's the same here. And so as more people burn out, and I think the way that even the system is, the way physicians and nurses and nurse practitioners, there's a lot of policy pieces, but even with clinics and people just not having access, and as continuing to try and provide care in similar models.
Mhm.
And there is a certain amount of flexibility that isn't afforded just also because of policy and the way that the provincial governments have mandated, and I'll tell you the way that you can and can't provide health and healthcare, and
Mhm.
also inequity in payment structures, so that I think a lot of physicians, I don't want to speak, I know I would be happy to work just paid a salary and go to a facility, and that's where I work, instead of having to be an independent business person and having to manage all this and pay all of these people.
Mhm.
Like, I just want to be a doctor. And
Yeah.
so I think there's a lot of other pieces that people don't realize get in the way and are extra burdens, or the fact that if you want massage therapy or physiotherapy, or you have a sick note, so if you have insurance, the insurance needs this, or if your employer needs a sick note, it's so difficult to get in to see your doctor. What if you don't have a doctor? How do you get regular screening if
Yes.
you don't have a family doctor? How are women getting PAPs and referrals
Mhm.
from mammography? Like, all of this is put on the burden of people who are already sort of overstretched and can't take on more. When
Yes.
realistically, we need to shift the system so that we can provide better care. There are a lot of healthcare providers who want to do that. That's why they came here. And it's the barriers that allow them to practice and actually help people that ends up, and then their well-being is affected, and they're being affected by the same environmental issues, and sort of how do you reach people in areas that are underpopulated?
Yeah.
There's a lot there. Um, but that's what I love, is change and difference and open-mindedness, and allowing people to also be more to participate more in their health and the caregiving journey, in hospital and out of hospital, enabling seniors to stay in their homes and stay active, enabling families with children with complex healthcare needs to care for them as all of these other issues are happening, and stay in their community, even remote communities. If thinking of the
Uh-huh.
families we care for in remote Indigenous communities who don't have consistent power, and how do you keep your child who has technology dependent in those communities? There's so
Yeah.
much that we
Mhm.
need to do better, and these are the conversations that we need to have. But as you point out, with government, because a lot of what we do, there's legislation or policy or funding. There are definitely many examples over the years of initiatives that people have wanted, but they have not been able to do. So, for example, in Ontario, virtual care. We were only allowed to do that, from a billing perspective in the pandemic, and that was almost repealed. Even though, I think of someone I know well who was a big advocate for children with disabilities, and he advocated for years to try and allow to facilitate virtual care because of the labor and cost, and even the health effects that their child had, bundling to go to these multiple appointments. Anyway,
Mhm.
it's a whole other area, and I don't want to take too much of a tangent, but to sort of pause and pivot somewhat, I feel like that might be an interesting segue. If you want to take a break, I'm happy with that as well. But an interesting segue into your new book, which is, I'm very excited to read, around, because I see the link, I see the connection, but yeah, the work that you're about to release. I know I've tried to order it and I haven't been able to order it yet, but the new book that's coming out.
Yeah, it's it's not me straying away from environmental racism because I don't come at environmental racism independent of health. So I center myself as a health researcher, and environmental racism and climate change for me are health issues. So I think some people might maybe expected me to do a follow-up book on environmental racism. And maybe that will come someday. I'll do another book. But right now I feel like I've said all I need to say about environmental racism.
Yeah.
I mean, the bill passed and that's interesting. So maybe there's a follow-up book. But I'm essentially a health researcher. And as I mentioned, my PhD and my postdoc were both on Black women's mental health. Mental health is my first love. And I never got a chance to publish my PhD. Time just passed, and I always said I would do it and I never did. So some aspects of this book come from the work I did during my PhD, particularly the historical parts of it. So I am looking at the Enlightenment, colonialism, a time when ideologies and perceptions of Black people were forged, and how those ideologies and perceptions of the Black body informed psychiatric diagnoses. And they certainly did, because Black people tended to be, and certainly I would say today as well, overdiagnosed or misdiagnosed with certain illnesses such as schizophrenia. And one of the things that I argue, and other scholars in Britain and United States have argued, is that the overdiagnosis of schizophrenia in Black men has everything to do with the perceptions of Black manhood and Black masculinity as something to be feared, as something that is aggressive and pathological. And schizophrenia is an illness that is also seen in many ways and has been portrayed in popular culture as to be feared. People with schizophrenia to be the most pathological illness one can get, and is dangerous. And I think of the movie with Jack Nicholson, One Flew Over the Cuckoo's Nest, that I looked at when I was very young. And I think he had schizophrenia. And typically at that time, and maybe even today, people with schizophrenia are portrayed in that way, as scary, to be afraid of, and as highly pathological. In the book, I also talk about how white women tend to be overdiagnosed with affective disorders like depression, bipolar. Black women underdiagnosed with those illnesses. So what I'm looking at is, in the book, at least in the first part of the book, the social construction of Blackness, and how the social construction of Blackness collides with the social construction of mental illness. And while what I argue might upset some psychiatrists, I believe that psychiatry is problematic. I think labeling is problematic. And I believe that ideologies about people, about race, often come to inform the ways in which we assess and diagnose and treat people within psychiatry. That might upset some psychiatrists, but this is what I truly believe. Lots of people have issues with labeling. I have issues with labeling, but I have issues with the racial underpinnings of labeling. So in terms of that first part of the book, I'm looking at colonization. I'm looking at slavery. I'm looking at the Enlightenment era, which is often referred to as the Age of Reason, and how ideologies about Black people influence their diagnoses. I'm also talking about racial trauma and intergenerational racial trauma, and how that gets stored in the body for Black people, causing illness, mental illness in many ways, and even physical illness. When we talk about trauma, we often talk about sexual abuse and war, but we don't often talk about race as traumatic. It's taken Canadians and Canadian institutions like the Canadian Mental Health Association a long time to validate race as a valid structural determinant of health. And in 2018, the Canadian Medical Association, I don't think I had that right, finally validated racism as a structural determinant of health. I didn't need them to tell me that, but anyway, their draft report, they said racism is a structural determinant of health in Canada. So I talk a little bit about that and how that was kind of a landmark position paper or draft paper that they put together. So I'm talking a lot then in the book about the structural determinants of health, some of those upstream factors like poverty and income insecurity, and the ways in which inequality and racism are embedded within our social structure, such as education, urban planning, labor, employment, environmental racism, and other social structures, how they come to be embedded within our social structures and have an impact on the mental health and well-being of Black communities who don't fare very well within those social structures. And much of that contributes to trauma, to racial trauma in Black communities specifically. I also kind of bring in some of my studies, original research that I've done over the past few years on Black women's mental health issues in Halifax, Black youth mental health issues in Halifax, and Black youth mental health issues in Hamilton. So some of the recent studies I've done where Black individuals are talking about their perceptions about mental illness and how they feel mental illness should be treated based on those perceptions. And there's a kind of diverse array of opinions that Black people have about mental illness and how it comes about. A lot of Black people, I would say, believe that, Black people have these kind of very strong beliefs about mental illness, which contributes to the taboo and stigma around mental illness in Black communities. Now, many communities have this taboo and stigma, but I feel it's stronger in Black communities. There's this idea that I think comes from Africa, actually, that if you have a mental illness, then the bad and evil spirits have gotten you. That you've done something bad in your family, you've done something malevolent, and now the evil spirits are punishing you. So that means that the only way you can address your mental illness is through prayer and praying very hard, or through a faith healer, or through other methods that are certainly non-Western methods. There's also this notion in Black communities that if you have a mental illness, you are weak. Some Black people will say that's white people's stuff. We don't get that. We don't get mental illness. White people get it. We're too strong. So if you seek out a psychiatrist or a mental health professional of any kind, you are weak. Pull up your bootstraps. Get on with it. Stop complaining. Those ideas that you are to be blamed, you've done something malevolent, you're being punished by the gods, that you are weak, perpetuate the stigma and the taboo around mental illness in Black communities, which often means that they underutilize mental health services or they don't seek them out at all. Because there is this belief in the community that you can do it. You don't need that. And that's harmful. It's also harmful because mental health professionals assume that Black people are strong. There's a notion, I would say, in society that Black people are not just physically strong, but that we are mentally strong and that we can take it. And that ideology, that perception that mental health professionals and other professionals, I would say doctors in general, have, then often means that we don't get the care that we need. So I talk a lot about that in the book in terms of the people that I spoke with. Many of them talked about these beliefs. They said that some of those beliefs influence them because it comes from family and it also comes from their culture. So I spoke to people in all these studies. They were from different African countries, probably primarily Nigeria, Caribbean countries, and Canadian-born Black people who shared similar ideas about mental illness. But what I also found is that Black people are starting to partake in multiple forms of self-healing and coping and help-seeking despite that. So, people talked about mindfulness healing. They talked about spiritual baths and yoga. And they also talked about seeing their GP and seeing psychiatrists. I think over the years, because I did this work for my PhD way back in 2002. And what I'm seeing is that Black people are partaking in what we call alternative healing methods increasingly. But I think what remains foolproof for many Black people would be spirituality and seeking help by church going and prayer. I think that remains strong despite the other methods that they might use to address health issues. I think spirituality, religion, church, faith remains the strongest coping method for Black people. So in my book, in that second part of the book, I explore all of that. And in the final part of the book, I talk about suggestions for mental health professionals, for health professionals in general, in terms of how racial trauma, can be addressed. And I talk about things like training, medical schools. What are they learning? What are students in medical schools learning? That they need to learn more about cultural competency, structural competency, about upstream factors that impact on mental health. So the training needs to be different. I talk about research. Much of it comes from research. Research sometimes is the root of much of this. So researchers need to start talking more about race as a determinant of health. I talk about funding streams, whether we're talking about SHIRK or CIHR. That I think things have gotten better. I'm seeing changes. There's a stream this year that came out on structural determinants of health. I was like, wow, I was blown away. But I think there need to be funding streams for Black researchers, but also for research on Black health. That needs to happen. I talk about community-based initiatives. I don't want to take the onus off of the health system at all because they're responsible for focusing on Black health more and addressing Black health issues. But there are great initiatives that originate in Black communities, because Black communities are seeing a gap in the health system. So they're taking it upon themselves to create initiatives. Once again, I think that's important, but I don't want to take the onus off or the responsibility off of the health system. They need to do that work. But I wanted to highlight the fact that there are community initiatives that come up that are addressing these issues. I talk about mental health policy. Mental health policy of any kind is the root of the problems that we see. We have decision makers, policy makers who get the opportunity and privilege to make policy. And those policies then influence programming and services and clinical services. So mental health policy needs to acknowledge racism as a public health issue and racial trauma as a valid mental health issue. And then I talk about the mental health system as a whole. So that final chapter is about what can we do? How can this be addressed? From a very holistic perspective, from the training in medical schools and the health professions, to research, to funding streams, to community-based initiatives, to mental health policy, and to the mental health system as a whole. So I wanted wanted it to be very holistic in terms of how I highlighted what needs to be done. So I'm very excited about the book, and I say to people, this is the book I always wanted to write. I did my PhD. I was planning to publish it, like many people plan to publish their PhD thesis, and life got in the way, and I'm finally doing it.
I know about 5 people who feel that way about their PhD. So there you go. But I think that there's this piece of spiritual health too, right? Like it's mental, physical, emotional, and spiritual health. Those are all important. And even in the way that policy, I know someone who's a spiritual healer, and how do they, when people come, you give an offering, but it balances all these questions around, we need more, in my view, spiritual healers coming in, not just from our major religions, but a more, how do we facilitate spiritual healing within the healthcare context?
Yes.
And at the same time, that needs funding, because that's not, so there's these pieces as well. And I think that spiritual piece is so de-emphasized, or it's either seen to people as very important or dismissive, when that's fundamental to our species for, thousands of years. And whether people have spiritual beliefs, even if they don't necessarily, I think from an atheistic perspective, you could still argue that some people may have spiritual beliefs. So yeah, that's interesting.
Thanks for listening to Hot Air, Cool People with Dr. Anna Gunz. If you enjoyed this episode, please follow the show and share it with a friend. In part 2 of this series, Dr. Ingrid Waldron helped us understand how environmental racism operates through systems, from policy decisions to health outcomes, and why structural change is essential. Her work on Canada's first environmental justice law shows what becomes possible when communities are heard and when lived experience is treated as expertise. In our final episode, we'll turn toward empathy, education, and what it takes to navigate difficult conversations while still holding space for hope. Special thanks to our guest and the Climate Change, Environment and Health production team. This episode was produced by Jakob Wilk and managed by Danielle Pineda and Olivia Brooks. Show artwork was created by Lainey Bolio. Details and links are in the episode notes. Until next time.